So now, now before we start to know the refractive errors, the status of refractive errors in children, and how do they develop, and then once you have an idea of how do they develop, then only you can manage. Now there is so you must always know the natural history of refractive errors. What is the natural history of the development of refractive errors in children and small infants? You see, the American Academy of Ophthalmology, the American Association of Pediatric Ophthalmology and Strabismus, and the American Association of Optometry, and the Royal College of Ophthalmologists of England have formulated certain guidelines for the management of refractive errors in children. That is what is important to know, and that's what we should follow. Now, for ease of understanding and measurement, the format is divided into two large groups. That is birth to 6 years and 6 years to 16 years, that is the end of the school age. Because by that time, 16 years, most of the refractive errors have developed or they have disappeared. So what actually we should also know in this series is what is emetropization. See, we always strive for emetropization, and we always want that the patient, the child, the infant should be emetrope. Now, emetropization is the process when the eye assumes a state of no refractive error. As growth of the eyeball occurs from 17 millimeters at birth to the 20 and then 21 and then 20, around 24, by 8 years of age, the cornea flattens and the lens from almost a spherical shape becomes elliptical. The final refractive state of no error comprises of an axial length of 23.7, this is approximate, 23.7 millimeters, lens power of 21 diopters, and the corneal power of 45 diopters. So this is a standard, and the ultimate refractive state that we all should develop. Now, there is a general agreement that most infants are hyperopic at birth, and the cycloplegic refractive error is approximately 2 diopters. This is a normal concept that when the child is born up to 6 months, this is what is the refractive state a child has. Now, this hyperopia, which is transient, disappears by first year of life. So by the end of 1 year of birth, the child should have an emetropic state, at least if the hypermetropic error is only plus 2 diopters. And gradually by 3 years, it should totally disappear when the eye becomes emetrope. That's what I was telling. Though in some cases, reduction continues up to 4 years and rarely up to 12 years of life. Therefore, in cases of myopia or in cases where the refractive error is high, we always keep on refracting a child up to 12 years and keep him under surveillance for 12 years to see if the total refractive errors may disappear by the time. And you start weaning the spectacles which you have given for hypermetropia. So this is one concept. There is also a higher prevalence of astigmatism at birth. Remember that, of 1 diopter or more. So this is all a natural. This is all a natural status of an infant, the refractive state of an infant when the child is born. There is also a higher prevalence of astigmatism at birth of 1 diopter or even more. All types of astigmatism are seen, which normally disappear by 4 years of life. It could be with the rule, it could be against the rule, it could be meridonial, it could be even, the double-crossed astigmatism, whatever it may be. Now, 30% of newborns also have anisometropia. That means difference of refractive errors between two eyes, which again disappears by 4 years of life. This transient anisometropia is due to different rates of emetrobization between the two eyes. So, suppose in one eye there is an hypermetropia of +2, for example, and the other eye does not have any hypermetropia. It could be emetro from birth also. It's not something unusual. So when the eye emetropizes by 1 year, 3 years, and 4 years, the rate of emetropization between the two eyes would be different. So when you come across such patients, you wait patiently for 4 years. If there isn't a cross, if the gross anisometropy is not there, you can patiently wait for 4 years, and then you can monitor the state of development of the refractive errors. Now, why this? So we have talked about hyperopia, we have talked about anisometropy, we have talked about astigmatism. Myopia does not exist in a newborn. Remember that. Myopia does not. If there is a myopia by birth, it is an ominous sign. It is a bad sign, and it is a sign which gives you an hint that the child is going to develop a progressive myopia. And you should, see, this is a different matter. After we can't discuss it here. It's usually done in a master class, where last year I had done it anyway. So so myopia is an ominous, is a bad sign. Be careful if you find an myopia by accident, because by 1 year or 2 years you do not refract a child until there is a problem. So until there's a problem of metropias or phoria, or if there is some problem, the parents bring the child usually with tropias, because exotropia is very common in early childhood myopias. So when you get that and you accidentally see that and you do a refraction and see myopia by 2 years also or 3 years, it is not a good sign. Anyway, now why this natural history is important? With now listen carefully. This is, you can even note it down and you can use it in your clinical practice. With hyperopic spherical equivalent of more than 5 diopters, means hyperopia per se of more than 5 diopters by 3 months of age, or greater than 3 diopters at 1 year of age. That's what is the research which they have found. There is less than 50% of chance of emetropization. That means such a child will not emetropize, and then it has repercussions. And those repercussions are that you might go into an amblyopia, you might go into a defective vision, and you might go a bilateral, emetropic amblyopia if the hypermetropia is more than that, or you may go into an esotropia. So this is what is the the cascading effect which has if the hypermetropia does not disappear. If it is more than 5 diopters by 3 months, or more than 3 diopters at 1 age, where you should start disappearing, then there are 50% of chance that it will not disappear. Now, astigmatism of more than 3 diopters of 1 year will not completely disappear. So it has repercussions again. Infants with refractive error and strabismus have, now see, the refractive error and strabismus, it could be a congenital accommodative, or it could be a congenital esotropia, infantile esotropia, have only 50% of chance of emetropization. Similarly, if an isometropia of 3 diopters, 3 or more, persists after 1 year of age, there is a high risk of remaining at development of amblyopia. So these are the parameters which, when you come across, when you are examining a child, which may come with the child may even come with watering of the eyes, pain in the eyes, when they start working at 3 years, or even they start playing with toys at 2 years of age or 3 years age. If the parents bring the child that there is a watering, it's an epiphora or red eye, signs of ocular asthenopia in a child, all these factors you have to keep in mind So you cannot just, wash away these things. No, 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 there is nothing important. You must investigate by a full cycloplegic refraction. Now, what are the implications of a persistive refractive error? Now we come to the exact management and meaning of all the topic we have today. What are the implications of a persistent refractive error which remains after 3 or 4 years of age? Because if such an error has been persisting and the emetropia has not developed or not occurred, there would be some problems in a child. And the parents would definitely bring to you, most of the parents who are educated will bring to you with some sort of symptoms. And therefore, what are the implications? You must know. Now, hyperopia. Because I have something here for hyperopia also, so with that. Now, children who maintained more than 3 diopters of hyperopia after 2 or 3 years of age were more likely to develop esotropia. Accommodative esotropia. We know that any hypermetropia of 2.5 or more, or even 2, we have seen patients even of 2 children. If they have an abnormal ACA ratio, they would even develop by 1 or 2 diopters also, they could develop esotropia. So are more likely to develop esotropia. Now, children with uncorrected bilateral high hyperopia, naturally it will come with uncorrected only. So children with, we'll put it this way, children with bilateral high hyperopia have a poor visual acuity. So I've seen many parents bringing their children who have gone to at least half a dozen ophthalmologists, who come at 5 years or 6 years, and their vision is not improving. They have signs of ocular asthenopia because they have started doing near work, and signs of ocular asthenopia, if not esotropia, at least the signs of ocular asthenopia would develop. And they do the refraction, they keep on doing the refraction, the child is not improving. The child is not improving because they have developed bilateral ametropic amblyopia and their visual acuity is poor. So that's a different subject, that how we manage amblyopia in such children. Now, studies have shown that in bilateral isometropic hyperopia, isometropic means both eyes having the same amount of hyperopia, of 4.5 diopters or more. These are all statistics. These have all been studied by pedic studies also last 2 decades. So last 2 decades, the pedic studies, what is pedic study? They have, it's a gross multi-centric studies done by the United States Strabismus Society and Pediatric Society, and they have formulated some guidelines. So this is all those studies, and we have concerns about that. So studies have shown that in bilateral isometropic hyperopia of 4 diopters or more, after 3 years, even without strabismus, 40% of children, means almost half of the children, have 612 or less of visual acuity. That means they have gone into a bilateral amblyopia. Now, poor accommodation and poor stereopsis are also associated with hyperopia, naturally, because there is too much of strain put on the accommodative system. In last year in the IAGO, I have a big article. I have published a big article on accommodative anomalies in children, which so far were not studied and were not relied upon, because it was assumed that in a child the accommodation is flawless, but it is not so. There are a lot of problems with accommodative anomalies in children. So in last year's IGO, that article has been published. You can see for that. So now the point is that poor accommodation occurs in high hyperopia, and then a vicious circle starts. And there's a cascade of complaints and problems there. Now, astigmatism. visual system is not very sensitive to astigmatism in the first year of life. We have a good heartening point here. At least we have a solace that astigmatism, which was previously supposed to be very detrimental in small children, is not so detrimental in very small children. Therefore, what it means is that the visual system is very accommodative and cooperative actually to even astigmatism by first year of life. So the visual system is not very sensitive to astigmatism in the first year of life. But after that, uncorrected astigmatism, particularly oblique astigmatism or bi-oblique, we are talking to, results in meridional amblyopia. Now, was the cutoff? What is the cutoff line where such an amount of astigmatism would create amblyopia? And so we'll come to that later on. Now, just listen now. With every diopter increase in astigmatism, with every diopter of increase in astigmatism, there is loss of one line of visual acuity. That starts after 1 year. Also, there is loss of grating acuity, vernier acuity, contrast sensitivity, and steer acuity. This is all we see after 6 years, because before that, these hyperactivities do not develop. And therefore, after 6 years, when in later ages, when the child comes to you for examinations, or he has complaints after 10 or 12 years when he's studying and going to higher classes, all these acuities will be hampered. And these all acuities, have a bearing in the working of a child, in the studying of a child, and in the activities of a child in the school. There's a big chapter on that in many books. Now, studies also show that astigmatism of one diopter of, now see, we are now coming to the point, what I was telling you, we are coming to the cutoff line. Studies show that astigmatism of one diopter or more after 4 years of life, because by 4 years, most of the astigmatism disappears. So you have to be very, you have to be not very aggressive in treating astigmatism before 4 years, because normally the patient does not even come, a child does not come before 4 years of life. In very rare instances, which I told you before, if there is an Atropine or there is an ocular asthenosclerosis and some other problems of watering, then only the child will come to you. But then do not, for God's sake, neglect the child, because watering epiphora has many causes in children. But one of the most important, most pertinent, and most significant causes are persistent refractive error. You see, don't neglect that. Don't undermine that. You may be all be thinking that there is a problem in the NLD and NLD and LLD. No. First, take the vision and do a proper cycloplegic refractive error correction or this thing. So studies show that astigmatism more than after 4 years of life should be fully corrected to optimize visual development. That is, astigmatism normally disappears 4 years later. Now, anisometropia. See, we are talking one by one. We are taking the subjects of all the types of refractive errors one by one, which is important. Now, one diopter or more of spherical hyperopic anisometropia. Now, spherical hyperopic anisometropia, you understand what I'm saying, causes amblyopia and other relative visual disorders, which we already talked about. So now, what is the cutoff line? What is the cutoff point where we should be serious about refractive errors in children? 2 diopters or more of spherical myopic, now we are talking of anisometropy, myopic, hypermetropic, or even astigmatic. So 2 diopters or more of spherical myopic anisometry, means 0 and -2 in 1 eye, causes amblyopia. So this is an amblyogenic factor. Similarly, 1.5 diopters of cylindrical anisometropic, hyperopic or myopic can cause amblyopia. Of all the visual functions affected, stereoactivity is the most affected. Myopia. Bilateral isometropic myopia of less than 4 diopters up to 6 years of age is not embryogenic. Now you see, bilateral and isometropic means myopia of the same degree in both eyes of less than 4 diopters up to 6 years of life. It's very simple. We can understand the child, before 6 years is just playing and understanding, so the visual effect does not come into the picture. Up to 6 years of life is not embryonic nor causes disturbance in other visual functions, because mostly the child is playing with toys and near work, so that vision is absolutely clear, absolutely crystal clear and crisp. So he does not have any complaints, neither any visual function disturbance occurs. Now, after 6 years, the child uses both near and distant vision, what I was telling you. And myopia not only hinders the visual activities, but is a stimulus risk factor for progressive myopia development. Now, antimetropia. What is antimetropia? It is not given in books, but it is there. It is now coming in vogue. One eye is hyperopic and one eye is myopic. That is antimetropia. Occurs due to unequal or disparate emetropization. Means in one eye, because of the disparate emetropization, one eye remains hyperopic, other eye may develop myopia, because in case of the process of emetropization results in the enlargement of the eyes. We all know that, from 17 to 24 millimeters. So therefore, the eye cannot shorten. That is one of the biggest thing. What is happening in in cases where the myopia is developing. This is a complex situation, and the visual disorder depends upon the degree of disparity, because there could be an amblyopia in one eye where there is hypermetropia, and the one eye. I have seen at least there are four patients with me at present in my treatment whose one eye is -6 and one eye is +4. So the +4 has gone into an amblyopia. -6 we cannot give refractive correction because of the massive aniscone it will produce, massive difference. So I am treating I have put a contact lens in one eye actually, and contact lens actually in both eyes, one hyperopic and one myopic contact lenses, and treating the amblyopic eye, the hypermetropic eye with patching. There are at least 4 still. One is already now 10 or 12 years of age, and I am now weaning off from the amblyopia treatment, but other 3 are still with me. So, this is a complex situation. You have to treat it with what I was telling you. Now, when ordering, now we have studied all this. Now we now know that what amount of these refractive errors cause which type of problems, and when we have to be serious, when we should take cognizance of this, and when you should treat them. Now we come to the other part of it, that is, when considering a spectacle prescription, the following questions should be considered before you start the treatment for these refractive errors. Now, is the refractive error within the normal range of child's age? Then it would emetropize within 2 or 3 years of age. You don't have to worry. Will this refractive error emetropize? We have seen that what amount of refractive error emetropizes, and we should not be concerned. Will this error disrupt the normal visual development? Will it cause amblyopia? Will this cause a diminution of vision? Will this error disrupt? Will prescribing spectacles improve the visual function or functional vision? This is a big aspect again. There's a half of a chapter in, So will prescribing spectacles improve visual function or functional vision? Visual function is what we see, and functional vision is the vision what we have already left with us. There are so many problems in a small children, retinitis pigmentosa, bilateral Leber's atrophy, and all these things, where the functional vision is only the vision which is left with a child of 10 or 12 or 14 years is only the functional vision. So how can you improve this functional vision? So that is another aspect of discussion. It's not the time here to do it. Now will prescribing spectacles interfere with normal production of emetropia? Again, this is now if you start treating a hypermetropia of 3 diopters, 2 diopters at 2 years of age, only 3 years, it will disrupt the normal process of emetrobization. I mean, the emetrobization would stop there because there is no impulse or stimulus. See, emetropization always occurs when there is an hyperopia. When there is an hyperopia, the eye always tries to compensate or contradict that hyperopia by enlargement. When this is what happens in the process of emetropization, the eye is always enlarging in a natural course. The lens is flattening, the cornea is flattening, eye is enlarging. This is the normal process of emetropization. So if you are too aggressive in this treatment, you might interfere with the normal process of emetropization, and you can artificially create a refractive error which would not have occurred. You understand my point? So now when prescription of spectacles is required, is crisp vision more important? Now this occurs in astigmatism, you know, that the patient, the astigmatism 3 or 4, the child may not accept. But this is not always, you know, you have to always get the 4 corrective error, because then the child would accept it. Now, will the child accept glasses at an age of 2 or 3 or 4 years of age? That is another point. Now, management. Now, there are some examples, you know. Management of hyperopia and astigmatism is more than an art, than a science. So you have to learn by experience. Hyperopia of 3 diopters or more after 3 or 4 years almost probably will not emetropize, though in some cases emetrobization continues up to 10 or 12 years old. So it should not be treated or not? Yes, it should be treated. Children with symptoms of headaches, asthenopia, blurring of vision, etc. need correction in an hyperopia. So symptoms usually arise after 3-4 years of age as the near work begins. Examination of such children have shown reduced visual acuity, reduced stereoactivity, reduced night vision, contrast, that is contrast sensitivity, lag of accommodation, impaired fine motor skills, and impaired visual cognitive ability. So this if the hypermetropia 4 or more after 4 years, you remember that cutoff line, it has not improved, it can cause these problems, and therefore it should be treated and needs correction. Now, how do you correct is a matter of art. Now, how much to correct? That's what is an art. If symptoms occur before 4 years of age, because if the parents bring because of the symptoms which I had already narrated you before, correct 2/3 of hyper. If it is 4, correct 3. After 4 years, correct the full correction of hypermetropia. Symptomatic cases have been reported even with 1 diopter of hyperopia, but these are rare, and mostly in these cases there is an esotropia because of the abnormal ACA ratio. Astigmatism. I would let me continue, okay? Because let me finish, because
sure, sir.
Okay, yes. Let me finish 10 minutes, because we have 1.5 hours. Okay.
Yes, sir.
Yeah,
no problem.
so
you can continue.
Let me finish this. I'm you know, taking all the three talks together. Okay.
I understand. Yes, sir. You can continue.
Now, astigmatism. With the rule astigmatism or against the rule astigmatism of 1.5 diopters or more should be corrected after 4 years. It means by 4 years this should disappear. All astigmatism of any type of astigmatism should disappear by 4 years of life. If this does not disappear, then you have to fully correct it. Oblique astigmatism, correct fully at any age, because meridional or oblique astigmatism or a bioblique astigmatism at any age, even if you detect it at 3 years of age, because the child usually come with that, or if there is a child comes before that because of Antimetropia, okay, because that is the only way the parents would bring the child to a doctor, otherwise they would not know, or there would be a watering. Ocular astigmatism develops only after 3 or 4 years when the child starts working for a year. So oblique astigmatism correct fully at any age. Myopia. This is a big area of discussion which has been going on for a long time. myopia up to 2 diopters or more undercorrect. That has been the normal teaching. As emetrobization is still occurring. See, if an myopia is less than 2 diopters, and if you correct it at 4 years, that stimulus for emetrobization would disappear, and then the process of emetropization would stop there, and the myopia would progress. So, but after 4 years, correct fully. Now, correction of less than myopia of less than 1 diopter is controversial. But in my practice for many years now, I always correct even 0.75 diopters of myopia, because we do not know that what is going to be the stimulus. What is going to be the stimulus for progressive myopia? So we want to stop all stimulus for development of progression of myopia. That's why always correct full myopia, even 0.75 diopters, and isometropia. Now, after 3 or 4 years of age, correct fully anisometropia of more than 1 diopter spherical hypermetropia, correct more than 2 diopters of myopic anisometropia, and correct more than 1.5 diopters. That means spherical hyperopic and hyperopia is more dangerous, more detrimental, is a more cause of concern because it causes amblyopia. So any hypermetropia, metropic and isometropia of more than 1 diopters after 4 years of age. Okay, 3, because if the patient comes to you early, it is 3 years of age. After 3 years, correct it fully. Myopia of more than diopters, correct fully, correct, and astigmatism of more than 1.5. So hyperopia 1, astigmatism 1.5, and myopia 2. If they persist after 4 years of age, they need correction and management and treatment. Is it clear? Now, pearls of refraction. So having said that, when you start now treating a child, who has come to you with refractive errors, and when you have now decided that this child needs treatment and correction, what are the parameters or what are the guidelines for managing this? Now, these are: refract in the line of vision of a child, not parafoveal or perifoveal. Use age-appropriate cycloplegic drug. In my book, which was published by GP Brothers in 2016, is a full book which is by the name of Correct Management of Refractive Errors and Correction of Spectacles. I have very clearly shown what the type of the cycloplegic should be used at what age. So age-specific cycloplegic drug is very important to show the full refractive error. Post-cycloplegic test is mandatory in every child. There have been cases in my practice also. I have done 6 years or 7 years child. He had some problem. Psychiatric problem. So I did not use cycloplegia. I used tropicamide, but there was a disparity in AR refraction. And when I called that child for post-cycloplegic refraction, what you called as PMT, also post-mediatric test, you can call it, or post-cycloplegic test, you call it. There was a lot of difference in what the child was accepting and what I had found in the cycloplegic refraction. So then I couldn't use the cycloplegic because of certain problems. So I used hometropine. And when I used hometropine, the actual amount of refractive error came out. So that you must always understand that if you find that with the autoraf, there is always it is not coming. it is always a disparity in each of the reading what you get it, or if there is a difference in what you have taken up, what you have found out, and in the refraction and the post-cycloplegic refraction test which you do, then you must always again do the refraction with a higher cycloplegic drug. Now, give full correction and acceptance in a child. It is mandatory that you give full correction, because that is what we want, is a crisp, good, clear vision in a child. And you will be surprised, a child even of +8 or +9 in my practice, there have been innumerable cases have after 10 or 15 days, they have fully accepted that +8 and the +9. I have seen many ophthalmologists, because they come to me ultimately, or they have been referred to me by the ophthalmologist and say that it is the child is not accepting and the vision is not getting clear, and there are so many other problems. But when you give, you have some patience and tell the child to keep on using glasses, and if you are, see, after a month or 2 months, the child is so fond of glasses that as just getting up in the morning, as soon as he gets in the morning, he asks for his glasses. So acceptance is phenomenal in a small child. So don't worry about the acceptance. Don't worry about the higher refractive error correction you are giving. The child would gladly accept all the refractive, even as astigmatism of 4 or 5. That was what I was talking to you, a crisp vision and the alleviation of symptoms. So crisp vision is more important in a small child for development of his normal process of visual functions than alleviation of symptoms. And you will be surprised, you will be astonished to know that what I was telling you just now, that a child so gladly accepts all these higher numbers within span of 15 days or 1 month or 1.5 months, and our purpose is solved. Now, care in high astigmatism, I told you, no refraction without a cycloplegia. Please, even up to 18 years, I do it even up to 21 years, do not refract, do not give spectacle correction without a cycloplegic refraction. Please, please, and please. That I have very categorically given in my book also, that there's a full chapter on cycloplegia, how to do refraction and all that. So it is published by JP Brothers. You can see it if you want, and a lot of people. Now this is what is from my book, that in what age what has to be given. We'll skip that. Now retinoscopy, as I told you, is an art. It is, however, an art which cannot be learned from books. That's why I am here. That's why I had written that book on refractive management of refractive errors, because I know, especially it is for all ages, but it's more impetus has been given in children. Is an art which cannot be learned from books. For efficiency can only be attained. See, this is an art, so you have to become proficient in that, efficient in that, and for that it can be only attained by long, assiduous, arduous, and painstaking practice. This is from a textbook of ophthalmology, Duke Elders, about how the refraction was done, and now we have better equipment in our armamentarium for refraction. This is an auto refractor for a small child, and and this is a photo screening. On the other photo is the photo screening. What is the mass screening we do for refractive errors? This is how the refractive. This is the fundus reflex which you get when you do a semi-dilated pupil from 1 meter, and the refraction, the fundus reflex should be equal in both eyes. That means that there is no refractive error. The Bruckner's reflex, we already know about it. How does it differ, and then how do you find out whether it is Atropia or the refractive error, or what type of a refractive error you can get from a Bruckner? This is basically a Bruckner's reflex. You know what you're getting. So, as an indispensable aid, and this is what I'm telling you from my book, in refraction, cycloplegia should be used as follows. Now see how important cycloplegia is. Cycloplegia should be done in all children compulsorily up to 12 years of age. Number one. Manifest refraction not compatible with vision up to 21 years old. But in my practice, because I've seen with the long years of my clinical practice that you should do it up to 20 years because there's always a disparity. And as I told you before, the post-cycloplegic refraction, I mean, the test is not compatible with the cycloplegic. You always use a higher cycloplegic. It is important. Whenever refraction yields variable results, what I told you, if you do 10 times an autoref or with your retinoscope with streak, you find every time there's a different variable result is coming, always use a higher cycloplegic. Symptoms of ocular asthenoscopy, irrespective of vision. I have done 2 theses of my postgraduates, 2 theses, and that paper has been already read in the last few AIOS conferences also, that patients coming with 6/6 vision, 6 vision, at least 30% of them after doing a cycloplegic refraction have manifested with hyperopia or hyperopic astigmatism, and that was the reason for ocular asthenoscopy. So you must always, in any symptom, even the vision is 6/6, because most of the time we see 6 and tell them that it is fine, your headache is due to your CNS problem or your vertebral problem, and go to that doctor, go to neurologist, go to ENT. No, for God's sake, please do a cycloplegic proper cycloplegic refraction in these patients. Now, suspected extraocular messenger, in all cases of phoria, because you are testing in a child, and if you find a phoria, even if not tropia, phoria, go for a full cycloplegic refraction. Then in infants and children where vision is difficult to assess, a lot of 2 years, even with Allen's or I have Teller's cards also with me. I try, but sometimes the child is not attentive. You do not get a correct assessment of the vision. Then you always go for a refractive error, correction of refractive error. In repeat refraction with stronger cycloplegic where asthenopic symptoms continue. Number. In actual or suspected ciliary spasm in children also do that. Now, atropine is very judicially used in all cases. I mean, especially I use it up to 3 years of life, not only 1, but 3, but only ointment. Now, remember this thing, this is very important. 1% of atropine contains 10 milligram per ml. We all know that. What is the meaning of 1%? The meaning of 1% is 10 milligram per ml. Now listen carefully. There are 10 drops per ml. That means 1 ml. There are 10 drops per ml. That means if you put 1 drop in the eye, you are putting 1 milligram per drop, because there are 10 milligram in 1 ml, 10 drops. 1 ml contains 10 drops. So that means one drop contains 1 milligram. So 1 drop, when you are instilling in an eye of a child, you are instilling 1 milligram. Now 1 drop in each eye yield 2 milligram. 2 milligram. Okay. Now 2 milligram in each eye. Listen carefully. 2 milligram in each eye. If you put it in both eyes, it is 4 milligrams. This is 4 times the adult parenteral dose. You only give 0.4 milligram when you get an IV atropine. So this is 4 times the dose of a parenteral in an adult. Therefore, only 1 drop each eye should not be exceeded. Okay, and that's why we always say that when you block the puncta for at least 15 minutes. You block the puncta for at least 15 minutes when you are instilling an atropine drop in a child of more than 4 years. If there is a necessity, because usually I give only home atropine, is very rarely when there's a lot of cycloplegic, there's a spasm, or there's a very high hypermetropia when you see with a normal refraction. Because after 8 years, I usually give 6 years, I usually give cycloplegia, cyclopentyl or tropicamide. But when I find that it is not reacting, I go for these hypertrophies. So I think I will stop here. These are certain examples which you can learn from that. I will stop here, and if there are some questions, then we'll discuss later on with these questions. Okay, thank you very much for a patient hearing. I assume and I hope that something must it must have affected you, and you'll be careful when you're managing a child with refractive. Thank you.